Thank you for joining us. Dr. Rizzo, I believe you can begin.
Thank you, Katie. I'm Matt Rizzo. Welcome to today's briefing on traumatic brain injury. I'm the chair of neurology at the Nebraska Medical Center, the Department of Neurological Sciences, and fortunate to be the chair of the American Brain Coalition. Cohen Veterans Bioscience and the ABC have partnered today with the Congressional Neuroscience Caucus and the Congressional Brain Injury Task Force to host this informative briefing on solutions for recognized critical gaps in TBI diagnostics and treatment. A few words about the Congressional Neuroscience Caucus. It's co-chaired by our friend, Congressman Earl Blumenauer and Congressman Kathy McMorris Rogers, and it's been going for about 11 years. It was established in 2010, basically for three reasons. The first is to build awareness of the key role brain research plays in understanding ourselves and society. Second, to communicate the progress and benefits of this important research. And third, to promote changes in federal policies that are needed to support neuroscience research. The Congressional Brain Injury Task Force was established about 20 years ago in 2001. It's co-chaired by Congressman Don Bacon, who actually happens to be my congressman here in Omaha, and Bill Pascrell. And that is having the purpose of advancing education and awareness of brain injury and supporting funding for basic and applied research, brain injury rehabilitation, and importantly, the development of cures. So today I'm really pleased to turn over the reins to our moderator, Dr. Chantel Ferland-Beckham. She's the Director of Policy and Advocacy at Cohen Veterans Bioscience, which I just mentioned. They're an ABC coalition member. Cohen Veterans Bioscience is a nonprofit brain research organization. It's based in New York City, and their mission is to advance diagnostics and therapeutics for precision brain health. Dr. Ferland-Beckham is a translational neuroscientist. She has over 15 years of experience in preclinical models of neuropsychiatric disorders and brain injury models. She's also a very experienced public policy advocate and professional. She spent nearly 10 years working on advocacy and public policy levels at multiple levels, local, state, and federal. After earning her PhD, her doctorate in neuroscience at Tulane, she completed postdoctoral fellowships in traumatic brain injury, as well as in clinical and preclinical models of comorbid addiction and post-traumatic stress disorder. So we are thrilled to have you, Dr. Ferland-Beckham. It's all yours. Take it away.
Thank you, Dr. Rizzo. Each year in the United States, over 40 million people seek treatment at an emergency room or healthcare facility for a variety of serious injuries. Of these, approximately 2.87 million are traumatic brain injuries, or TBIs. Despite the misconception that a TBI is an event that occurs in isolation, many who suffer a TBI often develop numerous long-term effects, including mental health conditions, cognitive dysfunction, sleep disturbances, and substance use disorders. This suggests that TBI for many individuals is a chronic disease. In the United States alone, an estimated 5.3 million individuals live with a disability as a result of a TBI, making TBI a leading cause of death and disability and increasing its personal and economic burden. These numbers are likely underestimates, as they are only based on cases identified in the emergency room and exclude individuals who either do not seek care at all or are treated outside of the emergency room. While management of the initial effects of TBI have improved in recent years, both clinicians and researchers agree that early TBI care and diagnosis may not accurately predict long-term patient outcomes. Therefore, for those who go on to develop chronic effects of TBI, many gaps exist in our understanding that limit the advancement of precision medicine solutions that will result in meaningful benefits to TBI patients. In recognition of a need to overcome these gaps through a collaborative team science approach, In 2019, Cohen Veterans Bioscience hosted a State of the Science Summit with over 100 thought leaders across academia, government, industry, and nonprofit organizations. The goal was to identify the barriers to meaningful progress in TBI and develop a roadmap of actionable research priorities that could serve as a blueprint for progress in TBI. All of the panelists in today's virtual briefing were part of the 2019 State of the Science Summit on TBI and have contributed to the development of the brain trauma blueprint. Today's briefing highlights some of the identified gaps and recommendations from the State of the Science and resultant publications to build towards a collaborative model to address these significant challenges. Before I introduce our first speaker, I'd like to remind everyone to feel free to ask any questions in the Q&A box on the screen at any time throughout this briefing. We have allowed for some time at the end to ask questions of our panel following their presentations. Our first panelist today is Dr. Patrick Belgowan. Dr. Belgowan is currently the Deputy Associate Director in the Division of Neuroscience at the National Institute of Neurological Disorders and Stroke. Prior to this, he served for 6.5 years as Program Director for Traumatic Brain Injury Research at NINDS. The NINDS TBI portfolio covers a broad spectrum of research from disease-related basic research to large clinical research programs. In addition to overseeing the TBI portfolio for NINDS, he is also programmatically involved in the NIH's Brain Initiative, the Human Connectome Project, and the NIH Neuroscience Blueprint Program. Dr. Belgowan, I will now turn it over to you.
Today, I'm going to talk. I'm going to give just a broad overview about TBI in general. I'm going to specifically drill down a little bit about some of the interagency coordination and collaboration that's been going on between federal agencies. So first, we'll start out with the CDC's description of that. Traumatic brain injury is when an external force is applied to the brain that causes injury. And it affects how the brain works. TBI was mentioned as a major cause of death and disability in the United States. And I think most importantly, and what people often forget, is anyone can experience TBI. So we are all susceptible to TBI. There are a couple of basic entry mechanisms for TBI that you should be aware of. The first and most common is blunt force injury. Among those is falls, automobile accidents, anytime you bump your head against something or has something bump against you. The second is blast exposure. So that's caused by an overpressure shock wave. This is usually when you're exposed to an explosion or firing large munitions. And third is penetrating brain injury, which firearm-related brain injuries are impaled objects. So people falling off from ladders with nail guns and accidentally shooting nails into their brain. There's lots of different causes for traumatic brain injury. The CDC Surveillance Report that was mentioned by Chantal is from emergency room admissions. And what you'll see in the 2016 and 17 is that unintentional falls are the most common and a leading cause of traumatic brain injury currently. And most relevant is the oldest age. So people over 75 are getting more and more TBI. So we're recognizing this. And why that's important is because these are also people who have some of the more complicated ways to diagnose and treat because they have comorbid conditions. And tools have been primarily developed for assessing TBI on younger adults. And then finally, always a reminder that suicide is the leading cause of TBI-related deaths through penetrating brain injury, so firearms-related, and they account for almost a third of all TBI-related deaths. And so this is just a little bit about how complex this is. So when I first started this, most of the field, we thought a little bit about TBI as this sort of multidimensionality, is more of a Rubik's Cube. So there's the dimension of age, there's severity, which we unfortunately still refer to as mild, moderate, and severe. There's nothing mild about mild TBI, which is what we're trying, that's one of the messages we're trying to get through. And then injury type, which we just talked about. But what we've been finding out for the past 10 years is that it's becoming more and more complicated. So severity, age, gender, time since the injury, the type of injury, the history, your history of injury, as we said, the comorbidities that you carry, the genetics affect the way you recover. And then we're finding more and more that social determinants of health can influence your recovery. So this is just there are even more factors. And so this just shows you the complexity of understanding traumatic brain injury relative to actually a lot of other diseases, is that there's so many factors that you have to account for and so many different types of injury. And for that reason, there's been an increasing amount. So this is the NIH TBI portfolio from 2008 to 2021. So the last 2 years, the numbers haven't been officially released, but this is from NIH reporting. What you'll see is this increase in spending on TBI, and that has to do with the expansion and more understanding of TBI, which has brought more and more people into the field, increasing the number of grant submissions and increasing the amount of research being done in this area. The primary areas of growth in TBI research is around mild TBI. Again, mild is a bit of a misnomer, but mild TBI and concussion. Biomarker development, so we've made great progress in developing biomarkers for diagnostics. We're working on prognostics and monitoring. And then, of course, studying the chronic effects of TBI, which was an area in which most people only thought of in severe TBI, but we now know is also something that happens in mild TBI and moderate TBI as well. So at NIH, there are at least 11 of the institutes that contribute to the TBI portfolio, and INDS is the lead institute, carries about 75 to 80% of the portfolio. But we study everything from basic in vitro research, looking at axon stretch, to phase 3 clinical trials in severe traumatic brain injury. And then we have a suite of translational grants that we also support. So we have the whole spectrum of research, and that's why I'm not really going into any particular area of it. But if you have a project you want to talk about, I'm happy to talk about it later. So as I said, what you see from our research in the past few years is that there's this evolving landscape in understanding TBI. And I think these are probably, for me, these are 3 of the most important points. The first is that mild TBI or concussion can result in long-term sequelae across the symptom spectrum. So as Chantal mentioned, it can be psychiatric outcomes, it can be pain, it can be cognitive problems, it can be basic functional outcome measures of quality of life can be disrupted long term. And this is, I know that it probably sounds obvious now, but 10 years ago, this wasn't necessarily something that people were thinking. Second is, across the injury severities, the recovery trajectories are very complicated, much more complicated than we thought. So more patients who have severe injury recover than we thought, and more people who have mild injury get worse over the span of a year or 2 years than we initially thought. So they start out better, and their quality of life keeps getting worse and worse. So, and there's a whole spectrum of recoveries trajectories in between, and this is one of the primary focuses of a lot of the research that we do in humans. You there's been a big change in the TBI field and understanding that TBI is a chronic condition. So once you've had a TBI, you may be more susceptible to other TBIs. You have all these other symptoms, these chronic symptoms. These other chronic symptoms you may be at risk for that we just talked about, and it seems that you may be at risk for other neurological disorders, such as some of the dementias, the Alzheimer's disease related dementias, and psychiatric disorders such as depression, anxiety, post-traumatic stress. So for a long time, all the federal agencies worked in sort of in silos. And in 2012, then President Obama released an executive order asking us all to work together to improve the lives of service members and veterans and military families. Out of that, Section 5 was in order to create a national research action plan. And there were three components of this, which is suicide, psychological health, and traumatic brain injury. This was a 10-year plan, and it was released in 2013, so it's ending in a year and a half, which is 2023. This plan has been really successful in bringing the agencies together, having us communicate more, understanding what research we're all investing in. You can see some of the themes that we've collaborated on, including biomarkers, diagnostic and prognostic markers, trying to diagnose who has a TBI, trying to figure out if they're going to recover, how they're going to recover, trying to improve the nomenclature, which is the mild, moderate, severe, trying to better improve that subgrouping, understanding the pathophysiology, which is going to help us develop therapeutics, and understanding treatments, which is both pharmacological and rehabilitation. So we meet twice a year in meetings to have discussions about progress in each of these areas, and then those of us on the boots on the ground meet much more frequently than that to discuss how our research programs are. So I wanted to show you one success of the National Research Action Plan. In 2013, NINDS released the Common Data Elements, which is the standardization of how to measure TBI and do assessments. And we funded a fairly large study called Track TBI, which then, as it fed through the National Research Action Plan, became a source of leveraging infrastructure. So we developed this infrastructure, and then what you'll see is that it was followed by more NINDS funding. So I highlighted the funding, which is looking at geriatric populations. It's looking at developing biomarkers. And then the DoD, FDA, Department of Energy, all also leverage this to do a variety of different studies. How do you move things to the FDA? Can we do precision medicine with this? What are the long-term outcomes? Finally, this last one, TrackNet, is a phase 2 clinical trial network that the DoD has stood up in order to advance and accelerate. So this is just one example of the many successes that the National Research Action Plan has produced. And I just want to emphasize that the reason this is so successful is because it makes the federal agencies and those managing those TBI portfolios in each agency to work together and understand what each other are doing. So again, to wrap up, I think that the things that are really changing in this evolving landscape of TBI are understanding these long-term sequelae. So understanding that people have long-term effects of particularly mild TBI, which is, when I first started this, was, people just shook their head and said, no, that's something else. It's not affected the TBI. That the recovery trajectories are complicated, and we need to understand them to do effective treatments, and that TBI is a chronic condition. And then my final slide is just that in NIH, TBI has also been involved in the ADRD funding opportunities relative to how TBI affects dementia, HEAL, and how pain is involved in TBI, and the Brain Initiative for advancing technology and understanding the brain. And that's it. Thank you.
Thank you, Dr. Belgowan. Our next speaker today is Dr. Rachel Ramoni, Chief Research and Development Officer at the U.S. Department of Veterans Affairs. Dr. Ramoni leads the VA's nationwide research enterprise, encompassing 2,000 active projects at more than 100 sites. Prior to joining the VA in January of 2017, she was on the faculty at Harvard Medical School in the Department of Biomedical Informatics. Dr. Ramoni's research interests include informatics, genomics, and precision medicine. Prior to her time at the VA, she led large multidisciplinary practical research projects, including the NIH-funded Undiagnosed Diseases Network, which has used close bedside bench collaborations to find answers for scores of people with conditions that have eluded diagnosis. Dr. Ramoni, I'll turn it over to you.
So, thank you so much. It's an honor to follow Pat Belgowan. We've worked closely together, as he mentioned, under the National Research Action Plan. Here is a kind of an overview of what I'm going to cover. Our work intersects with the National Research Action Plan, and we've made several investments in that vein. We're now poised to do the all-important work of identifying subtypes of TBI so that we can better tell people what their future health is going to look like or their prognosis, as well as identify precise treatments that will treat their subtype of TBI. One major source of this information of this classification will be leveraging data that we already have. And I'll talk a little bit about that. And, it's my belief then that we will accelerate progress if we find ways to share our data more seamlessly while respecting veterans and service members' privacy. So just to orient you, one slide, I am the head of the Office of Research and Development, and the Office of Research and Development sits within the Department of Veterans Affairs, which, like DOD, is a cabinet level agency. So what I hope to persuade you of today is a few things. And as was mentioned by Chantel Ferland, is that I led the coordination of the Undiagnosed Diseases Network, an NIH-funded project that continues to seek diagnoses for people with mysterious medical conditions. And this in many ways was my greatest teacher. The secret sauce of that network isn't really a secret, since it's within its motto, solving medical mysteries through team science. And I think the same applies here, which is that we need to work as a coordinated team across organizations in order to provide answers to people whose lives depend on those answers. I also learned through that network a phrase that has stuck with me, which is time equals lives. The faster we go, the more people we can help. That same kind of urgency, the systematic team-based approach that enables efficient scientific progress towards real-world goals is what our service members and veterans living with the consequences of traumatic brain injury deserve. The will exists, obviously, to work as a team, as is evidenced by the National Research Action Plan. And we're now poised to build upon that work to ensure that a service member or veteran gets the right treatment at the right time for his or her TBI. To do that, we need to first understand that there is not going to be a one-size-fits-all treatment for TBI because it is not a singular entity. Imagine trying to come up with a vaccine for to prevent COVID-19 if we fail to distinguish SARS-CoV-2, the coronavirus that causes that, from the many coronaviruses that cause the symptoms of a common cold. It would be a total and complete disaster. We wouldn't have gotten the vaccines in record time, and a lot of time, money, and lives would have been wasted, and we'd still be living in a pre-vaccine world. So to give our service members and veterans the TBI diagnoses, prognoses, and treatments they need, we have to become more precise in how we classify subtypes of TBI and then consistently use these subtypes in clinical care and research. It's important that these subtypes be based upon the mechanism or the series of events that led to the symptoms rather than just what the symptoms themselves are. The reason is that the treatments need to be targeted to the mechanism of the disease rather than the symptom. The same symptom may be caused by different mechanisms of disease. So to bring it back to the COVID-19 example, consider that many infections will lead to a fever. But to effectively treat or prevent a fever, you need to know what chain of events led to this. So I hope I've convinced you this is important. The problem is that things that are important are not necessarily easy. As Pat went over, there are many dimensions to TBI, and this will take a careful dissection of that data in order to identify these meaningful subtypes that go along with prognosis and point us to to appropriate treatments. The great news is that we have a wonderful place to start from now that we have this NRAP up and going, and that a blueprint has been developed collaboratively. For example, VA has a ton of data in its electronic health record. We have information dating back to 1999, and we have complete medical record information on 16.6 million veterans, including 10.6 billion lab records. We also have access to imaging data, the importance of which will be covered later in these presentations. In addition, we have data collected for clinical research studies. And I want to highlight here one of the National Research Action Plan activities, which is called the Long-Term Impact of Military Relevant Brain Injury Consortium, Chronic Effects of Neurotrauma Consortium, or LIMBIC-SENSI. My goodness, is that a mouthful? To fill in the gaps in knowledge about the basic science of mild traumatic brain injury, determine its effects on later in life outcomes and neurodegeneration, and to identify service members who are most susceptible to these long-term outcomes, and of course, treatment. It's co-funded by DoD and VA. Over 1,600 veterans have enrolled and are being followed, including imaging analyses, and it continues to enroll service members and veterans who've experienced mild traumatic brain injury during the course of their military service. And so I've included a link in case you want to spread the word about this so that we can increase our knowledge base in this area. In addition, we have the Million Veteran Program, which is not specifically targeted to traumatic brain injury, but we have information on a huge number of veteran partners. We have over 830,000 veteran volunteers. And so to put that in perspective, that's 100,000 more people than the entire population of the state of Alaska. The results are being shared in very high quality scientific journals. You'll see one here in Nature Genetics, one of the premier genetics journals, which is a very large study identifying genetic factors that predispose people to or that are correlated with post-traumatic stress disorder. And again, I want to highlight that MVP is still actively welcoming veteran partners, including women veterans. And we have launched, we are in the process of launching something called MVP Mind, which will do more in-depth analyses on brain health and on mental health. So one of the challenges is that only a small number of VA investigators can access these MVP data at present. And to address this challenge, we are establishing a VA Data Commons in collaboration with the University of Chicago and the Open Commons Consortium, which support several data commons, including the Brain Commons. It will allow both approved VA and non-VA researchers to access de-identified data from VA's electronic health record and also the Million Veteran Program study. And we're really excited about the potential for this to advance our understanding by bringing the best minds to the data. And we expect a pilot launch in the upcoming fiscal year. So another effort we're undertaking is to advance translational work. So to identify safe and effective treatments for TBI subtypes, we need to have preclinical or animal models that have the same characteristics as the human subtypes. There are currently many different preclinical models for TBI, and we are proud to be able to support in VA an interagency resource center to coordinate preclinical TBI research. It's a collaborative effort. We have great partnership from DoD and NIH, and we're funding it. And you can see the photo to the right is of a preclinical imaging group in Columbia, Missouri at the VA Medical Center, and that is a little baby PET scanner for mice. The Resource Center will create an online catalog of preclinical models of TBI. We are going to coordinate experts to refine, harmonize, and standardize procedures so we have greater rigor and reproducibility of findings in these preclinical models, which will also help us to refine and reduce our use of animals in research, something dear to me as a vegetarian. And we will develop plans for data commons for sharing high quality data from preclinical testing. And of course, as we learn more about the subtypes of TBI, the preclinical models will improve. So it's a sort of a virtuous cycle there. So I hope that I've succeeded in persuading you that TBI is not a single entity and that we have to work together to identify its subtypes. That coming up with accurate diagnoses and prognoses as well as effective treatments requires working together in a coordinated manner. And to do so, we have to be able to share data efficiently in a way that shows the utmost care for service members and veterans, privacy and confidentiality. And finally, I really hope that you feel the urgency as we do of the phrase time equals lives and appreciate that barriers to our progress on this collaborative effort should be eliminated in order to save more lives. We have a plan, we have a blueprint, and the time to act is now. And I thank you so much for your attention.
Thank you, Dr. Ramoni. Our next speaker today is Dr. Magali Haas. Dr. Haas is Chair, CEO, and President of Cohen Veterans Bioscience. Dr. Haas has over 15 years of pharmaceutical executive experience, predominantly at Johnson & Johnson, where she assumed broad end-to-end development leadership roles in early and late-stage neuroscience clinical development, translational medicine, diagnostics, and integrative solutions. To pioneer new approaches for precision therapeutics for brain health, she founded Orion Bionetworks in 2012, which was transformed to Cohen Veterans Bioscience in 2015, while also serving as founding Chief Science and Technology Officer for One Mind for Research. Dr. Haas earned her BS in Bioengineering from the University of Pennsylvania, an MS in Biomedical Engineering from Rutgers University, and her MD and PhD in Neuroscience with distinction from Albert Einstein College of Medicine. Dr. Haas, I'll turn it over to you.
Thank you, Chantel. And first, on behalf of Cohen Veterans Bioscience, I would like to thank Congressman Pascrell, Congressman Bacon, and the other members of the Congressional Brain Injury Task Force for their work over the past 20 years to increase awareness of brain injury. I would also like to thank Congressman Blumenauer, Congressman McMorris Rogers, and the members of the Congressional Neuroscience Caucus for promoting federal policies that highlight the importance of brain research for society and ensuring brain health is prioritized at a level that is commensurate with its impact. As you've already heard from Drs. Belgowan and Ramoni, anyone can experience a traumatic brain injury, and we can see here that there are many potential causes of brain injuries, including caused by motor vehicle accidents, falls, sports, and military service or abuse. We have witnessed over the last decade a profound amount of progress in our understanding of traumatic brain injury, and particularly in acute and severe trauma. However, most injuries that occur more than 80% of the time are mild injuries, or what we call concussions. And this refers to the severity of the injury at the time of the injury, not its cause or its consequences. At this time, in the United States, we have no single system for tracking the occurrence of head injury over our entire population. As Dr. Furlan-Beck mentioned earlier, we only count those individuals that show up in an emergency room or counted directly through the healthcare system. But many of us hit our head or have an injury and simply go back to work, go back to home, and that injury is never reported. It is important that we establish some kind of a national surveillance system so that we know how many individuals are in fact affected by traumatic brain injury. It's also important to note that while we've made a lot of progress, the prevalence and impact of traumatic brain injury is really high, but the outcomes following TBI have not changed substantially over the last 25 years. So despite thousands of preclinical studies in laboratory animals and hundreds of randomized controlled clinical trials, which were well designed and well executed, today we still have 0 US Food and Drug Administration approved drug therapies for the treatment of traumatic brain injury. So we have a sense of urgency to change the paradigm in order to advance these discoveries from the bench to the bedside. And as Dr. Ramoni mentioned, one of the major issues that we face is how we define and how we subtype traumatic brain injury. In fact, the definition of traumatic brain injury varies across institutions and studies, and this inconsistent classification system can be very vexing. But the real issue is that when you look at how we describe traumatic brain injury, whether in the acute stage, right in the aftermath of the trauma, or in the chronic stage, we're still referring to symptoms or behavioral manifestations, not the biological mechanisms. We're not where cancer, diabetes, cardiovascular disease are in terms of disease understanding. CBB is our mission, and what drives us at CBB as a public charity biomedical research and technology organization is advancing brain health by advancing precision medicine solutions. We, along with the Brain Trauma Foundation and other foundations, and you will hear from BTF later in this webinar, have a deep focus on advancing precision solutions for traumatic brain injury. And thanks to the National Research Action Plan, we've seen significant investments by the government, by the DoD, the VA, the NIH. And let's see if this, does this advance now?
Yes.
Okay. We've seen significant advancements in the understanding of the biological underpinnings of the various types of traumatic brain injury. And we believe that we are now at a turning point or a crossroad in our understanding, so that enough fundamental building blocks have been established that we can now start thinking about developing precision therapy solutions. We are seeing significant advances in biomarker discovery efforts leading to new diagnostics, and now we have the ability to start thinking about targeted therapeutics. So what I wanted to discuss a little bit about is when we talk about a biomarker, we're talking about a biological basis of understanding of these conditions, an objective way of measuring what's happening in the course of the disease biology. And there are many different ways that biomarkers can be used to both understand what's happening in terms of diagnosis, but also to understand what's happening in terms of response and the biological pathways that underlie these conditions. There are many different types of biomarkers that we can be using in our research, and we do. There are fluid-based biomarkers, including genetic markers, proteomic markers, different molecular substrates in your blood that we can measure. There are neuroimaging biomarkers, and you will hear later from Dr. James Stone about how these can be used to identify and diagnose traumatic brain injury. And we are increasingly seeing wearable devices, wearable sensor devices being used as well, and as biomarkers for TBI. In fact, so much progress has happened in the last decade in the realm of acute biomarker diagnosis that we now have 6 approved devices from the Food and Drug Administration, including fluid-based biomarkers from Banyan Biomarkers and Abbott, BrainScope, which is using EEG-based biomarkers, and Impact, Infrascrand, and Oncologica, which is using eye tracking to help aid in the diagnosis of traumatic brain injury. However, what you can see is we still have work to do in terms of developing therapeutics. So this is the turning point that we're talking about. The important thing about biomarkers is that not only are we using them now for diagnosis to identify who has traumatic brain injury and identify who is affected, the next stage now and in our advancement is to determine what are the subtypes within TBI. As Dr. Ramoni mentioned, it's not one condition, it's many conditions and many subgroups within the population. What we want to do is subtype those populations or stratify them so that we can then make sure that we're giving the right treatment to the right individual for the right type of disease that they have. And so there's more work to do to advance biomarkers for stratification, biomarkers for prediction, and for treatment response. To that end, we came together collectively, the government, industry, and the foundations in a seminal event called the Brain Trauma Blueprint activity. And the purpose of this Brain Trauma Blueprint was to advance the first generation of targeted therapeutics for the secondary injuries associated with TBI. Through this Brain Trauma Blueprint initiative, we held our first State of the Science Summit in 2019. And the reason we did this is because road mapping is a proven approach to align gaps with potential solutions, to communicate research priorities and allow cross-institutional planning teams to align resources and prioritize investments. Roadmaps make strategy work. And if we can all understand where the core issues are, and we can reach a consensus on the priorities, then we can also ensure that we're aligning limited resources to those actionable research priorities. And we can also ensure that we're tracking whether those investments make sense, whether we're getting a return on our investment. So in the wake of this first State of the Science Summit, we identified 6 areas of research gaps, including in epidemiology, phenotyping, looking at preclinical translational models, biomarkers, clinical trial design, and implementation science. And these research gaps led to specific recommendations that are now being published in the Journal of Neurotrauma, starting last month with an article on phenotyping, the spectrum of trauma, and now this last week with an epidemiologic survey looking at the chronic effects of traumatic brain injury and recommendations needed there. 4 additional articles will be published over the course of the next 2 months in the Journal of Neurotrauma, so please stay tuned and learn more about what we recommend as a path ahead to develop precision diagnosis. If we're successful in our quest to align resources and to these gaps and to these priorities, we will move away from the standard where we're using behavioral readouts of disease to one where we will have a biologically based approach to disease diagnosis, and that will allow us to then target specific treatments to the individual in an N-of-1 approach. I thank you for your attention.
Thank you, Dr. Haas. Our next speaker today is Dr. James Stone. Dr. Stone is Associate Professor and Vice Chair of Research in the Department of Radiology and Medical Imaging at the University of Virginia. He is an interventional radiologist and neuroscientist. His laboratory currently explores questions related to improving the clinical diagnosis of TBI in both preclinical models and human subjects. Ongoing preclinical work includes the design and investigation of molecular imaging probes for the detection of the acute and chronic effects of TBI. He is also involved with work exploring neurovascular changes in blast TBI models. Human subjects' efforts focus on exploring neuroimaging correlates of repetitive, low-level blast exposure in military populations. The goals of this work include determining whether operational personnel exposed to blast are at risk for developing long-term neurological consequences. Additionally, Dr. Stone is involved with efforts to build a normative library to support improved population-level research and work to assess patients with TBI using advanced neuroimaging. He is also involved with work utilizing machine learning, deep learning approaches for the automated segmentation of diagnostic imaging findings for TBI, as well as the joint analysis of multimodal imaging and non-imaging data in a common framework. He also oversees a national imaging core laboratory to support multi-center clinical trials utilizing imaging. Dr. Stone, I'll turn it over to you.
Thank you, Dr. Ferland. Appreciate that introduction. So today, I'm going to talk a little bit about an initiative that's being supported by Cohen Veterans Bioscience to build a brain imaging library. This is an activity that has widespread applicability across a number of areas of science and medicine, particularly related to traumatic brain injury. But what I'd like to focus upon today is specifically the clinical use cases around this as it relates to the development of the next generation approaches to precision diagnostics. So neuroimaging in general is a field that's a little over 100 years old. The first neuroimaging examination was done back in 1919 with the performance of an air ventriculogram. Since that time, there's been significant expansion in capabilities around neuroimaging that have included the ability to look at the brain in 3 dimensions using CT, using magnetic resonance imaging to open up views into brain structure and function, various ultrasound-based approaches for looking at flow within the brain, and various molecular-based approaches as well. Despite this significant expansion in the ability for us to be able to acquire imaging that's occurred over the decades, the ability for us to be able to pull information from those acquired neuroimaging examinations and the workflows related to that have remained relatively static. And so the typical workflow in the clinical setting is after image acquisition, the imaging is provided to a neuroradiologist that will look at that information and will generate a descriptive report that will go into the medical record. And then the practitioner will use that information in order to be able to manage care. This approach has been extraordinarily helpful for moderate to severe traumatic brain injury, where a routine clinical neuroimaging examination can reveal urgent findings such as an epidural hematoma seen here on the left or a subdural hematoma seen here on the right. Magnetic resonance imaging offers additional abilities to be able to see things that are occurring within the brain, such as this microhemorrhage that's seen here on the left, or the astroglial scarring that's seen on the right. But when we look at the area between these focal areas that we see using routine clinical interpretation, and we look at biomarkers with postmortem tissue analyses, there's a lot that's being missed with routine approaches to looking at the brain using neuroimaging. And we're really just seeing essentially the tip of the iceberg here with routine neuroradiological approaches. And for that reason, neuroradiology and its ability to be able to help guide care is really confined to moderate to severe TBI, and it has a relatively limited role in mild traumatic brain injury and concussion, which constitutes the vast majority of traumatic brain injury that's seen annually in the US and globally as well. And so in recent years, there have been techniques that have emerged, advanced neuroimaging techniques that have allowed us to be able to push the boundaries in what we're able to see with neuroimaging. These are approaches that allow us to be able to see changes, microscopic changes in white matter, which we know occur in traumatic brain injury, allow us to be able to see changes that are occurring on the molecular level and on the functional level as well. But these approaches require the acquisition of a large number of brain volumes, sometimes with brain volumes that are acquired over time. And they require computational tools in order to be able to derive specific measures, such as understanding how thick the cortex is, understanding whether there's a loss in white matter integrity or whether there are changes in functional connectivity. So these are all derived measures that are extracted from this large amount of brain information. And although the human visual system, which is really the keystone for the way in which routine clinical neuroimaging is presently interpreted, although that system has really evolved to be able to pick up discrete findings such as this epidural hematoma or the subdural hematoma, we're really not all that well equipped in order to be able to see the diffuse, subtle, and somewhat abstract changes that are associated with some of these more advanced tools. And that's really an area where computationally based platforms can be extremely useful in order to be able to mine this advanced neuroimaging data on a numerical level and to be able to try and elucidate some of these subtle changes that can be correlated with a loss of function and capability in traumatic brain injury. Now, to date, a lot of these advanced neuroimaging approaches have really been confined to research. Again, these are numerical quantitative outputs that, for the most part, have been used within research in order to be able to compare one group to another group to see whether there are differences between those groups and to try and understand the overall foundation of disease. However, what we really need to be able to do is to be able to push these advanced neuroimaging approaches out into the clinical area to be able to ask and answer questions in the context of the individual patient. Does this patient have a traumatic brain injury? How severe is their injury? And will they recover on their own or do they need some type of treatment? And we'd like to be able to be asking and answering these questions, not just in the context of moderate to severe traumatic brain injury, but to be able to address this within mild TBI and concussion as well. And this is where our normative data comes into the picture. So a neuroradiologist, when they're undergoing training, will see a lot of different examples of normal brains and abnormal brains, and they'll learn the patterns of abnormality on those brains in order to be able to arrive at a specific diagnosis. And there really is no difference in terms of that requirement for training when it comes to computational platforms. Apart and aside from the fact that when you are training a computational platform, you need a lot more data. And so humans have sufficient capabilities around abstract thought in order to be able to only require a few examples of abnormality in order to be able to distinguish between normal and abnormal. But computationally driven systems need large data sets. And so what's really needed in order to push these computational clinical approaches forward that allow us to be able to move advanced imaging data from research to the clinic is a normative library, such as the subject of what we're talking about today, a comparison of that with large-scale injury and disease data sets, and by comparing those two large data sets to be able to actually extract predictive features to generate a repertoire of diagnostic and prognostic features, and to be able to then use that as the foundation for machine learning-based computational diagnostic approaches in order to be able to move forward precision diagnostics and further the field in general. And so this is really the core of the normative neuroimaging library approach. It's a foundational building block in order to be able to bridge the gap between research and clinical approaches for advanced neuroimaging. It addresses this rapidly expanding need for quantitative diagnostic neuroimaging tools to really push advanced neuroimaging from research to the clinic. And this specific activity has been very thoughtful in the way the protocol has been put together, uses scanner harmonization, and then also utilizes standard neuropsychological assessments, medical screening, and a variety of other different approaches in order to be able to ensure that we understand the context for each of the individuals that are included within the library. Now, several years ago, Cohen Veterans Bioscience recognized that this was a critical need. And so based upon an understanding of this core need to facilitate science and medicine in general, they helped to assemble a group of academia, including Baylor College of Medicine, the University of Virginia, University of Utah, and then DoD partners down at the San Antonio Military Medical Center, including our Army and Air Force partners as well. And enrollment to date has been over 1,200 subjects and still going with a variety of different characteristics of that population to date, as shown here. And so performing an interim assessment of some of the data that's been acquired so far within the brain library, we're able to see some expected correlations between things such as brain volume and age, which are known correlations that are known to occur with neuroimaging. We're also able to see correlations between sex and brain volume as well. And we're able to look at various functional or self-report measures, such as the neurobehavioral symptom inventory, and see that the NSI correlates well with measures such as functional connectivity. Now, where some of the assessments of the brain imaging library get really interesting is that by using joint multiple modality approaches to brain imaging, so looking at the various different modalities from structure to physiology to function, we're able to look at that unified data and to actually predict cognitive scores on using toolkits such as the NIH Toolbox, which opens up an entire set of questions around how multimodal imaging can be used in order to be able to predict cognition. And we're able to use those multiple modality approaches in order to be able to predict things such as brain age and to be able to understand how each of those individual predictors contributes to that determination of brain age. So just to summarize here, again, the Normative Neuroimaging Library has recruited almost 1,200 subjects. The preliminary analyses so far have demonstrated expected relationships between age and sex as they relate to brain volume, along with other measures as well. We're able to do some really interesting and powerful predictive assessments using some of the multimodal information that's available within the library to predict things such as age and cognition as well. And the library acquisition is ongoing. This acquisition is going to be driven by this rolling analysis of the data in order to be able to understand the effect size that's associated with the variability of the data and drive recruitment towards the effect size that's important for the overall goals of the effort. In fact, starting this year, in addition to the imaging acquisition and the non-imaging contextual information that we've been acquired, there's going to be a collection and storage of serum samples in order to provide molecular and genomic correlates of the acquired imaging as well. And it really is the hope that as this activity evolves and as there is high quality normative data that begins to become more and more widely available, that it's able to be matched with large scale disease databases such as the TRACK-TBI database and that Dr. Belgowan referred to, and the Sensi Limbic database that Dr. Ramoni referred to, in order to be able to really feed the critical information that's needed for these quantitative imaging platforms. And the hope is that we'll start to begin to facilitate neuroimaging having a greater role, not just within moderate to severe traumatic brain injury, but also within mild TBI and concussion. So our view on the into the brain utilizing imaging can evolve from what's really currently more of a global perspective to having a better understanding of what's actually occurring on the ground level as well. So with that, I'd like to close with acknowledging what's a large and broad team and just a wonderful group of investigators to work with. And thank you very much for your time and attention.
Thank you so much, Dr. Stone. Our final speaker today is Dr. Jamshed Gahar. Dr. Jam Gahar is a board-certified neurosurgeon, president of the Brain Trauma Foundation, clinical professor of neurosurgery at Stanford University, and the director of the Stanford Performance Center. He completed the MD-PhD program at Cornell University Medical College. During his residency training in neurosurgery at Cornell New York Presbyterian Hospital, he invented and patented several neurosurgical devices that are currently used worldwide. He founded the Brain Trauma Foundation in 1986, which develops and implements evidence-based guidelines for severe TBI that have led to a 45% decrease in mortality. He has been the principal investigator developing and implementing scientific guidelines for TBI from concussion to coma with funding from the Department of Defense. He joined the neurosurgery faculty at Stanford in 2014. Dr. Gahar, I will now turn it over to you.
Thank you, Chantal. Let me just share my screen. Do you see my screen okay?
Yes.
Okay. Thank you very much. So I thought I'd give the historical perspective and also a view of how evidence-based guidelines can really impact outcomes. And the way that we traditionally look at TBI is mild, moderate, and severe. And I agree with the other speakers that it's not a good way of describing things, but my slide's advancing now. Do you see okay? Chantal? Okay.
Yes.
So I want to give you a little historical lesson on evidence-based guidelines and their impact on coma, severe TBI. And before 2000, we did a survey of all the trauma centers in the United States and found there's very little brain pressure monitoring, people getting steroids, they're being hyperventilated, under resuscitated, and the mortality was 50%. So if I had, back then, car accidents were the #1 cause of TBI. A young person came into the ICU in coma. It's a 50-50 chance of them making it through. And we just accepted that. But there was good evidence to show that we should do brain pressure monitoring. We should not give steroids. We should not hyperventilate. We should fully resuscitate TBI patients. At that time, methodology came out for doing evidence-based guidelines. We picked it up, and we were the first guidelines in any branch of surgery in the 1990s. And we put it into effect, and the mortality dropped by half. It dropped to 25%. So how did that happen? We started off with the Soros Open Society Foundation funding us to go to Eastern Europe and train the neurosurgeons there. We're in 44 hospitals in 8 countries. And as we taught the guidelines, the compliance with the guidelines went up and the mortality dropped by 50%. We took that database called TBI Track and we put it into New York State in 22 trauma centers. And again, compliance with the guidelines went up and mortality came down 45%. So dramatic decreases in mortality with application of best science in practice. But it's one thing to come up with guidelines, another one to implement them. The CDC came out with a report on the impact of the BTF guidelines and found again about a 50% decrease in deaths and a cost savings in terms of long-term outcomes. Now the guidelines are used in every trauma center in the United States and also internationally as well. And neurotrauma care is recommended to follow the BTF guidelines. These guidelines are constantly updated. We just came out with, in September, with an update on decompressive craniectomy, which is used very often for people with severe traumatic brain injury. We've done combat guidelines, guidelines for the ambulance workers, pre-hospital guidelines. And these guidelines are translated worldwide into different languages and used around the world. The newest one is the blast penetrating TBI guidelines for the military that we're now just starting to work on. This is a big concern for the military, and they haven't been updated for about 20 years, so we're going to do that. One thing about guidelines is that there are many people that give their time and volunteer towards guidelines. And I want to thank all the neurosurgeons and other providers that have contributed to the BTF guidelines. The American Association of Neurological Surgeons, the Congress of Neurosurgeons, and the Joint Section Neurotrauma and Critical Care have been key partners in helping us develop guidelines and then putting them into practice. And putting the practice is really the difficult part. And so trauma centers who follow the American College of Surgeons recommendations, put the Brain Trauma Foundation guidelines into practice, are key in implementing those guidelines. One thing we have is this continuous improvement. We develop guidelines, put them into trauma centers, and then we collect data on those patients. And then that leads to further evidence and improvement in the guidelines. So it's a continuous cycle of improvement once you put these guidelines into practice. Well, that's severe TBI, that's coma. What about concussion or mild TBI? We just finished the guidelines for mild TBI, concussion guidelines, a couple of years ago and published it. We had many authors on these guidelines. University of Pittsburgh were major authors on this, as well as the chief medical officer of the NFL. And the concern was in concussion or mild TBI, we really didn't have a good definition. And what we came up with the previous conference that was in Pittsburgh that came up with phenotypes, and then we decided to make it subtypes of concussion, where there's certain things that we can pick up in mild traumatic brain injury, where actually we can identify the deficit and have treatments to improve the outcomes. So we had vestibular balance problems, oculomotor problems, cognitive fatigue, headaches, they're really migraines, and anxiety mood disorders. Sleep and cervical strain were two associated conditions. And there's good evidence to support these subtypes in really defining mild traumatic brain injury. So with the Cohen Veterans Bioscience blueprint, the brain trauma blueprint, we have a roadmap now to move forward for evidence-based solutions. And we're going to be working with them to look at subtype clustering, trajectories of these subtypes, and then eventually therapeutic interventions early on to prevent the chronic effects of mild traumatic brain injury. I'd like to close and thank my colleagues at the Brain Performance Center at Stanford, Angela Lumber-Brown, who's a lead author on the CDC mild traumatic brain injury guidelines, Odette Harris, and Jerry Grant. Just showing here, the Stanford magazine published the 5 types of concussions and actually made caricatures of them. So again, vestibular, oculomotor, anxiety, mood, cognitive, and headache and migraine. And with that, I'll go off and happy to take questions.
Thank you, Dr. Gahar. I'd like to open it up right now to the Q&A portion of our briefing and encourage you to ask questions in the Q&A box, which we will try to get to as many as possible. So I'll go ahead and start with one of the questions that already came in. We have seen a lot of advancements in other areas of brain health using genetics to look at prognostics or risk factors. What are some of the barriers to TBI for using genetics, and what is needed to really be able to be more informative about the genetics of TBI?
I'll take a stab at that. I think we've seen that genome-wide association studies that have been conducted in other conditions like post-traumatic stress disorder, Alzheimer's disease, and so on have made a significant difference in our understanding of the biology and the risks associated, genetic risks underlying these conditions. I think in TBI, people don't think of TBI as having a genetic underpinning, and there hasn't been as much investment in genome-wide association studies in order to understand if there is a genetic component to this disorder. Now that we have all of these very large, deep cohort studies that have been funded, we have an opportunity to finally pull together this genetic data from all of the different sources to enable us to do a global GWAS study in traumatic brain injury. And I think if we did that, we would start to see the types of advancements that we're now seeing in post-traumatic stress disorder and other conditions.
Thank you for that answer. Does anybody else like to add anything?
Yeah, I can add on top of that. So I think I agree with Dr. Haas, and one of the issues about coordinating efforts across agencies and even more globally is to be able to collect enough of those samples in order to be able to do a GWAS relevant study. So the NIH, the Department of Defense, or formed a collaboration with the European Union at one that was working called INTBER, and they had a large observational study called Center TBI, in which they have, I think, 12,000 patients. And so as you start to, get samples from large studies globally, you start to be able to have enough to have an impact on understanding. Because as you know, as we all demonstrated, there's a lot of diversity in how you get the injury, who gets the injury, what the circumstances of the injury are. That can also affect recovery. So you're going to need very large numbers in order to pull out genetic risk factors.
And, and this is Rachel, and I would just reemphasize something that seems sort of boring, but is foundational to this. Two things, actually. One, having coordinating centers to proactively identify all of these studies that can help to inform our understanding of the genetic risk factors for consequences of traumatic brain injury. And also then the ability, again, I'll reemphasize what I said in my presentation, the ability both technologically as well as from a regulatory perspective to share these data, to pool these data, to analyze across these data sets. And it's not the sexiest topic in the world, but it is absolutely foundational to making the types of discoveries that require large numbers, as was just said.
Thank you. We had another question that's related to what can we really do to improve the reporting of TBI cases beyond the emergency room? As many of you have mentioned today, most of the numbers that we know for TBI are likely underreported. So what are some steps that we can take to really improve how we actually know, who is actually getting TBI?
I mean, there are conferences in sports, for instance, that keep track of that. The Pac-12 has the Brain Trauma Task Force, and there's a coordinating center at the University of Colorado that tracks all the Pac-12 concussions. The NCAA has, for a long time, with funding from the Department of Defense, been tracking concussions. But those are, Division 1 and 2 schools. And so, but then in the sports area, they have a very good collection system.
There's also a pilot study that the CDC embarked on to determine whether surveys of the population at large could be used to assess the prevalence of traumatic brain injury. And again, these are TBIs that are occurring outside of the emergency room setting. And we would advocate for an expansion of that program to establish a national surveillance approach through this survey approach. And that could also be enhanced further with a registry program where individuals who wanted to volunteer could be tracked longitudinally, which is another thing that we lack, is long-term longitudinal data to understand what the trajectory of disease is for TBI, especially to the chronic neurodegenerative consequences like CTE or Alzheimer's disease. So by building such an infrastructure, we could essentially kill two birds with one stone.
I would just like to then ask a question of Magali along these lines, especially as you mentioned for a mild traumatic brain injury. Do you see space for wearables to help contribute to, people reporting potential mild traumatic brain injury that doesn't lead them to go to the hospital?
Yes, I think digital technologies, wearable and sensor technologies have come a long way, and we're starting to see that they're being deployed to monitor chronic conditions and how you do over time. Not only do I think that we can use those to detect, to monitor disease, but we could also use it to track response. For example, if we were looking at sleep, which is a major component of traumatic brain injury symptomatology, we could be delivering cognitive behavioral therapy for insomnia and then using wearables to determine whether they are, in fact, the sleep hygiene is actually improving the outcomes, and create a closed loop system of monitoring and treatment for sleep just using digital technologies. So I do believe that these technologies have a lot of potential. And I also think telehealth services that have become more ubiquitous in the United States since the pandemic started can also help support these types of solutions.
Thank you, Magali.
Thank you.
So we had a question that came in about what is being done to identify and diagnose some of the psychological disorders as a result of continuous subconcussive trauma from things like sports or even other types of repetitive head injuries.
So from federal perspective, NINDS and NIH fund several studies on that measure exposure to subconcussive hits and concussion and include psychiatric outcomes as outcomes. And the DoD and NCAA funded the study that Dr. Gajar mentioned earlier about called the CARE study, and that's recruited 35 or 40,000 athletes already, and so analysis of those are underway. It is a good question, and one of the challenges is getting people to understand that potential association between traumatic brain injury and psychological symptoms is complex, but is real, and it's an area that needs, I think it's an area that's rich for more study.
Would anyone like to add to that, or?
I mean, it's a major subtype of the subtypes of mild traumatic brain injury is mood disorders. And it is a major component of patients that I see in clinic who come months or even years later, where they have significant anxiety and depression as a result of traumatic brain injury. So we recognize it. I think that it needs to be recognized and treated early to prevent long-lasting effects.
I would like to add that, in fact, because these symptoms look very similar to other conditions like major depressive disorder, post-traumatic stress disorder, there is a high degree of comorbidity of these conditions in these populations. And we do need to start thinking about how we can develop transdiagnostic approaches and bring the TBI and the psychiatric communities closer together to work together on developing better tools for diagnosing and identifying the subtleties that we see in these populations. It's not straightforward to distinguish between PTSD and TBI in some individuals, for example.
And I'll just add to that, much as it's important to understand the overall psychological sequelae of traumatic brain injury and associated mood disorders, it's important to understand how pre-existing mood disorders can alter the overall course of traumatic brain injury. There's some, at least anecdotal information suggesting that, pre-existing anxiety disorders can have a pretty significant impact on the overall course of even mild TBI and concussion. And that's certainly an area that's ripe for further study.
We had several questions that came in related to non-pharmaceutical treatments for TBI. So there are a lot of different options that are being explored out there. Where are we in terms of the research on some of these alternative treatments for traumatic brain injury, and what do we really need to have to be able to kind of move those treatments forward?
I'll just make a pitch for, there's low-hanging fruit. There's these subtypes identify impairments in patients, and they have to be measured and treated. So if people have, vestibular balance or ocular motor problems, essentially, attention problems, it should be recognized. And then things like you shouldn't be driving a car, you shouldn't be doing these kind of things, you're putting yourself at a risk for injury, are very important. So I think there's low-hanging fruit in terms of making sure you recognize there's an impairment and then giving a person advice to prevent further injuries. We also know there's good evidence for early exercise promotes recovery from concussion. So that's in there. And I think there's very simple things that can be done. There's obviously advanced treatments that need more clinical trials, but I think that the recognition that people can have attention and balance problems is important to recognize and make the person aware of that. And then there are treatments, vestibular therapists control it, optometrists are involved in ocular motor impairments, and people get better. So I think it's important to pick up on that first.
Yeah, and so the challenge with clinical trials always is identifying the patient population that's going to be effective. So if as was just mentioned, if you're treating someone for ocular motor issues and they don't have ocular motor issues because you included all comers, then it's going to affect the outcome of your trial. And so that's has always been one of the challenges in these, and why we need these markers and these subtypes to be defined so that we can recruit best for trials in mild TBI. NINDS is currently funding a phase 2 clinical trial for, as someone mentioned, the hyperbaric oxygen. It's called the Hobbit trial. And that trial is for severe TBI though. The military, DoD has run several trials for hyperbaric oxygen in mild and has not shown effectiveness. So, but we're still waiting for the results from our trial. But the challenge with, I think one of the keys about all these presentations was one of the challenges in running mild TBI clinical trials is being able to subtype and get the right patients in the right trial for the right treatment. And that's what's been missing. And that's where we're on the verge of being able to do. And I think that's where the advancements are going to come from.
Yeah, and I'd like to just build on Dr. Belgowan's comments to just relay that it's really important for us to have good diagnostic tools to be able to perform this subtyping in an objective fashion. If we're running a clinical trial that is looking for a relatively subtle signal within the brain and the only neuroimaging tool that we have available to us is CT, we're not going to get very far with that tool. So it's really important that as there are approaches that are being evolved around therapy, that our ability to be able to measure the effect of these approaches within clinical trials is advanced as well.
And to wrap up with the last talk we heard is, getting the results from clinical trials is one thing, getting them implemented is another. And so that's why the clinical trials have to be strong, and really have to have a good protocol for these, particularly these non-biologic or pharmaceutical treatments. If you're doing exercise, or if you're doing something else, you really have to have a standardized protocol that people can adopt broadly across different treatment centers so that it can be adopted.
Thank you, guys. Well, I see we're getting to the top of the half hour. If we've not answered your question, we will try to follow up with you directly to provide you with an answer. I'm going to turn it back over to Dr. Rizzo to close out the briefing.
Thank you. Many thanks to all of our speakers today for their thoughtful insights and cutting-edge science. I'm sure we all learned a lot. We're really grateful to have members of Congress and their staffers, ABC members, and other supporters of neuroscience research on this Zoom today. For members of Congress and your staffers, we have a couple of requests. And the first is to assure robust and sustainable funding increases for biomedical research, including brain injury research, everywhere that it happens, at the NIH, the VA, the CDC, Department of Defense, and elsewhere. Second, for House staff, if your boss isn't a member yet of the Congressional Neuroscience Caucus or the Congressional Brain Injury Task Force, please suggest that they join. Thanks so much to the Congressional Neuroscience Caucus, the Congressional Brain Injury Task Force, the Cohen Veterans Bioscience for partnering with the ABC and hosting this briefing. It was inspiring. It shows a great path forward for TBI. So please stay safe, everybody. Have a great day, and we really hope that we'll see you next time. Bye-bye.